right, guys, here's the nitty gritty. Let's talk about your role as a nurse in taking care of a patient who's had a stroke. Now, you guys should congratulate yourselves. You made it through this whole stroke module. So, let's talk about a couple things. So, first of all, our priorities for these patients is monitoring and safety. Now, safety is always a huge concern for every patient, but for our neurological patients and for our stroke patients, it's even a greater concern. Now, we're going to monitor their level of consciousness and neurological status, including orientation, strength, and pupils. All right. If a patient has just arrived to the emergency room, we'll do a neuro check like every 15 to 30 minutes for a couple hours, and then we'll do them hourly after that. If a patient's been on TPA, we're also going to do these neuro checks every like 15 minutes for a couple hours, then every 30 minutes for a little bit, then every hour, and then we get to regular neuro checks. But in the ICU, usually for these neuro patients, you're on like Q2 hour neuro check. So really important that we understand a full neuro check. So if you need a reminder on how to do neuro checks, make sure you go and watch our neuro check assessment videos, because I think that'll be a lot of help. Now, if a patient has vasospasms or rebleeds, we're going to start to see new stroke symptoms. Okay. So that's going to happen generally like 2 to 5 days after our hemorrhagic stroke. If we have a patient who's gotten TPA, what we're also looking for is those TPA patients can then convert and end up having a hemorrhagic stroke as well. Okay, so we're really watching these patients very closely. All right, you really got to keep a close eye on these stroke patients. They're very, very critical patients, and we really got to make sure that they're recovering and they're moving the right direction with their improvement. Now, as far as safety goes, remember that patients who have had a stroke are at risk for seizures. So we need to make sure we have these patients set up with seizure precautions. That's going to mean padded side rails. That's going to mean suction, giving anti-epileptic medications. If those have been ordered, they should be ordered, and possibly even having Ativan at the bedside. We're going to want to maintain a really quiet environment for these patients. All right. Not only to help minimize their ICP, right? It's all about ICPs with these patients, but also to minimize any frustration they may have because of these symptoms, right? This is all brand new to them. They haven't been used to this. It's all new things for them. So we really want to keep a quiet, calm environment for these patients. All right. Now, anytime you have a patient with hymenopia or visual field loss, we're really going to want to approach them from the unaffected side. All right. We want to approach them from the unaffected side. And then we also want to start teaching them to look towards the affected side. Now, that might seem it might seem like, why would you even have to teach them that? But remember, they're basically starting like a child, because this is all new to them. So you really have to teach them, look, you can have a plate of food in front of them and they can't see half the plate of food. So you really have to instruct them to make sure they're scanning their entire environment. All right. Now, if they have any residual weakness, we're going to provide assistive devices like walkers, canes, and get them involved with physical therapy very quickly, and occupational therapy, so these patients can get back and be safe and start ambulating as quickly as they can. Now, what happens here if these patients have like dysphagia is they're going to get involved with speech therapy as well, and they're going to be involved to help assess their ability to swallow. All right. What you're going to see is strokes really start to become a very interdisciplinary action. You're going to have all kinds of different providers on board, all kinds of different interdisciplinary teams on board. So it's really important that everybody just kind of works together for these patients. So the most common residual effect besides weakness in stroke patients is aphasia and dysphagia. So we're going to talk about both of those. Let's talk about aphasia a little bit really quick. So remember that aphasia can be receptive or expressive, depending on whether they've had difficulty comprehending or communicating. So we want to make sure that we give them plenty of time to respond. Don't talk to them really fast. Give them enough time to respond. We're also going to repeat ourselves with these patients, and we're going to leave a lot of space and only give one instruction at a time. We also want to reorient them to both person, place, and times, but also names very often. So we might have to remind them like, hey, this is a pin, simple things like that. Or my name is John, I'm your nurse. And you might have to say that every time you go in the room. My name is John, I'm your nurse, okay? And just taking it a little bit slower with these patients. And that can be hard. But I've had a lot of experience, you have to sit with these patients and take your time and only providing one instruction at a time with these patients. Okay. Now, instead of saying to your patient, like, I want you to sit up, swing your legs over the side of the bed, and stand up with your head up, instead, what you would do is you're going to say, all right, sit up. And we may even have to repeat it with gestures. So once they sit up, then you can give them one more instruction. You say, now swing your legs toward me, and so forth. So we really try to keep it simple. The other option we have for these patients is can use what's called a word board or a picture board. It's going to look something like this, and your hospital or your facility should have something like this to help patients with expressive aphasia. And what they do is they point to what they need, they point to what it is, or they can point to yes or no. We really ask them yes or no questions. Are you hungry? No. Are you tired? No. Uh, do you want the air turned down? Yes. And so they really can point. So if they have this aphasia, they can use this word board or this picture board. Now, I once had a patient who had expressive aphasia, and they can only say, So as soon as they got this word board in her hand, she was so excited because she was actually able to communicate. Remember, communication is such a base thing, and it's taken away from these stroke patients. So when we give them this ability to communicate with us again, imagine how good that would feel. All right, let's talk about dysphagia really quickly. Dysphagia is difficulty swallowing because of weakness in the muscles of the throat. Okay, so we're going to have throat muscle weakness. Now, in stroke patients, the speech therapists have the final say in if the patient is ready to eat or not. And you really need to listen to them and work closely with them. All right. Now, so we keep these patients in PO until they're cleared by speech therapy. Of course, NPO means nothing by mouth. It's actually like nothing per os or something like that. But you don't give them anything by mouth until they're cleared by speech therapy. Now, if they do show that they're at risk for aspiration because they can't swallow appropriately, we need to put them on aspiration precautions. This means smaller bites, sitting them up right when they're feeding, and sometimes a special diet. Now, the speech therapist will be able to tell you exactly what diet this patient needs. So, again, work with them in this picture over here. What you're going to see, this would be a puree diet. In our fundamentals course, we have a cheat sheet on all the different kinds of diets and like what mechanical soft is versus puree, or and how patients would advance through all these different diets. But many facilities even have little molds that they can push like the pureed peas into, so at least looks like real food, which is nice, and it gives these patients again that kind of sense of, okay, well, that looks like food. Okay, and again, this is going to be very hard for these patients. So the biggest thing I'm trying to get across, guys, is just be patient with these patients and be kind to these patients. They're going through an enormous life alteration. So patient education for stroke is actually a core measure measured by the Joint Commission. So it's important that you understand these things. There are certain things that we have to educate our patients on before they can be discharged after a stroke. Now, one of these is whatever their modifiable risk factors are. Now, the most important one being smoking. All right. This is the most important thing that we can teach them and they need to do. Now, we also need to teach them about their medications, like if they're on nimodipine or if they're on statins. We need to teach them about all these new medications that they're taking. They also need to know how important it is to follow up with their neurologist and any warning signs of a stroke that they need to report. So please teach them this, how to follow up and where to follow up. And again, we want to teach them what the fast mnemonic means: facial drooping, arm weakness, slurred speech, and time is tissue. Call 911 quickly. So we have to teach those patients those things before they can even go home from the hospital after having a stroke. So just to recap, our priorities with these patients include monitoring neurostatus, including level of consciousness, pupils, strength, and their NIH stroke scale, which we've talked about a little bit. Now, we want to focus on functional ability and optimize to get PT, OT involved, get speech therapy involved, get them assistive devices that they need so they can go home and start living a functional life. That's our whole goal, right? Is to progress them to be able to live a functional life. Now, we also want to pay close attention to their safety and prevent aspiration or falls when they start walking. So safety is such a huge issue. They're going to have to modify their home. They're going to have to modify all their devices. Safety is such a big issue with these people, especially when we start talking about dysphagia and stuff like that. Now, and finally, we need to make sure that we educate the patient on their modifiable risk factors. This is going to include things like smoking, all their medications, and we want to educate them on the warning signs. FAST. Woo. All right, guys. Make sure you check out the care plan and case study attached to this lesson to see more detailed nursing interventions and rationales and to better understand what caring for a stroke patient really looks like. You guys, pat yourself on the back. You've made it through the entire stroke module. That's awesome. So I hope you have a better understanding of stroke. Hope you have a better understanding of what a nurse should do. And I hope you guys can now go out, take care of these patients, have the compassion, and have the knowledge to take care of these patients and give them the care that they need. All right. Now, listen, we love you guys. We want you to be confident, competent nurses. Let us know if you have any questions. Now, go out and be your best self today. And as always, happy nursing.